Good morning, everybody. So this morning I've been asked to talk about Plaster of Paris. So I'm going to talk sort of around the topic a little bit, sort of go through some of the history of it, why we use it, how we use it, some of the problems with using it, and then also some of the ways that we judge whether we've done a good cast, I guess. So I'll go briefly through fracture management or the history of it. So for many centuries now we've been treating fractures, and it started off using splints, and the techniques have got progressively more complex as we've gone on, starting with sticks and palm fibre through to using different compounds to stiffen the bandages. So this is a picture taken from a Egyptian mummy for a fellow with a mid-shaft femoral fracture that was managed with a splint. I think this shows why we don't use splints much anymore. So then moved on to using plaster bandages. So Avicenna was an Arabian surgeon. He was the first to use plaster. He published his works in the Canon of Medicine, and he used linen bandages with calcium oxide that he got from seashells, and then albumin taken from eggs to stiffen his splints. Ambrose Paré was a French military surgeon for Napoleon that made his cast of wax, cardboard cloth and parchment. And Paré's given us a few things. I think he's more known for hip spikers, and he also developed tourniquets and ligatures in amputation surgery. Dominique Larrey then went on to, was the first to describe the use of a rigid dressing. So he treated a infantryman that had an amputation, and he put on this stiff bandage, and then after the soldier returned home, he was at sea for about 3 months, and they took the bandage off. He found that the wound had healed underneath. So he'd taken from this that immobilisation was good for soft tissues and for healing. This was then reproduced by Beaumont in animal models, showing that immobilisation and stiff bandage was good for healing. And then Louis Soutin, he modified Larry's technique by adding that protective layer of wool between the limb and the bandage. A lot of the problems they had with these back when they first started doing is they took a long time to dry, and there's 2 to 3 days of not doing much in order for the dressings to set. We then move on to Antonius Matheson, and he's proclaimed as the father of the modern plaster class. So he was a Dutch military surgeon that was the first to describe the use of plaster bandages. So he used coarsely woven materials that he'd impregnated with calcium, with plaster, and then moistened them with a sponge, and then described his technique of moistening them with a sponge and then rubbing them and contouring in order to set the bone in the position that it was required. So we've got progressively more complicated, and initially bandages were made by hand in hospitals, and it wasn't, this is a picture taken during the Second World War showing how they made those, and it was not till 1931 that the first commercially available plaster bandage came out in Germany, but due to costs and things it wasn't widely adopted early on. So the modern bandage is muslin cloth stiffened with dextrose and starch, and impregnated with a hemihydrate of calcium sulfate. So coming up to what we're using today, the gypsona. So Plaster of Paris gets its name from a large gypsona deposit in Montmartre in Paris. The story came about that they found the use not only in medicine but also in plastering, building and things, from a house fire in Montmartre, that they found that when it rained next day, that the footprints that had tracked in the part of the gypsona had set hard on the floor, and they adapted it from this. So gypsona is calcined gypsum that has been heated 150 degrees Celsius to form the hemihydrate of calcium sulfate. When mixed with water, it makes an exothermic reaction to move from the insoluble calcium sulfate to the soluble, the soluble to the insoluble. The compound expands by 0.5%. The setting time begins at 10 minutes and lasts for about 45 minutes before it's fully set. And this is the time that it takes for the plaster of Paris to move from a powder form to a crystalline form. It's then the drying time is about 72 hours, and that's moving from the crystalline to the anhydrous form. So these numbers vary briefly depending on different types of brands of plaster, and there's also some fast setting, but it's essentially a rough guide. So there's a lot of uses for plaster of Paris. We use them obviously for conservative treatment of fractures, and this employs the concept of relative stability as opposed to absolute stability, and uses the idea of a functional reduction rather than an anatomical reduction in some cases. And so immobilising fractures in plaster allows for control of alignment rotation. And they say length, but I think that's debatable depending on the limb and type of cast used. We also use it to correct soft tissue deformities. I think the most commonly known would be the Ponseti method for club foot. And we also use it as splints for resting injured and infected soft tissues. There are complications in everything that we do, and I think it's sort of important to remember that I think Charlie said this, that there are no hypochondriacs in cast, and essentially saying that if someone's complaining of something and have a problem, don't ignore it, and we should should check that there isn't a problem. So the complications can range from pain from a too tight cast, getting pressure sores, thermal injuries, all the way to compartment syndrome. So again, I think it's important to remember there are at-risk patients, and having a high index of suspicion is important for these patients. So those that are obtunded or comatose, those that have had regional blocks, the very young and the very old can find it difficult to communicate the problems they're having, so we need to be aware of those as well as not communicate with patients. And those with impaired sensation, and patients with spasticity are known to be at really high risk of pressure sores. So this is a picture of a young boy, I think, that had a plaster put on for treatment of a tibial fracture that had a compartment syndrome, and this is what they found when they took the plaster off, a missed compartment syndrome. This is a picture of a thermal injury from applying a plaster or a splint. And this is probably the more common one that we don't see regularly, but it's not unheard of. It's the pressure sore from a bent arm cast. So there's a few ways to avoid complications. I think the first thing is you should have a good technique, not applying the plaster too tight, and being mindful of having an even application of both the padding and the plaster in order to avoid pressure sores. Being aware of those at-risk patients. There's been several studies that have looked into what contributes to contribution of a thermal injury. And most studies would say that the threshold for the temperature of the dipping water should be about 24 degrees. That anything more than that has a high association with thermal burns. And there's been some in vitro studies that have shown a water temperature of 50 degrees has an internal plaster skin contact pressure of 82 degrees. So that's obviously very high. The threshold for thermal burns is usually quoted between 49 and 50 degrees, so it's something to be mindful of. Also, the thickness of the plaster is known to increase the risk of thermal burns. It's generally thought that greater than 8 plies is associated with thermal burns. Also, allowing the cast to dry on a pillow, which I think is something that we probably do without thinking more often than we realise, but it does impair the ventilation around the plaster and can increase the temperature, as well as overwrapping with fiberglass before the plaster is fully set. Has an appreciable difference on the internal temperature. So just going through the types of casts we use, historically there's been 3 types. So this is the unpadded cast, the padded cast, and then the badly padded cast. So the unpadded cast was popularised by Bowler in the 1800s. So he was the first to document and develop the principles of maintenance of reduction, immobilisation in fracture management. His plaster is applied directly to the skin with no intervening fabric, and he felt that the closeness and even the adhesion of the plaster to the skin enhanced his fixation and resulted in better outcomes. He describes that when the plaster is being put on, it should be rolled around the limb. It should never be lifted, never pulled tight, which is a bit different to some of the other methods. I think this has largely gone out of fashion, but there's some work, particularly by Charnley, that says that this is still in his opinion at the time, the preferred technique for the treatment for applying plaster slabs, but also for the treatment of scaphoid and Bennett's fractures. So remember, just a quick thing on Bowler, he's probably also well known for Bowler's angle, but he was also the first to document the trauma principles of save the life, save the limb, life, limb, and then organ, which I think we still use today in many circles. So the padded plaster, this was Charnley's preferred technique, and he wrote quite a lot on it. So the difference here is that there was a cotton wool or a fabric interposed between the skin and the plaster. So Charnley thought that it was the elastic pressure of the cotton that enhanced his fixation. It's a bit different to the way we do it today. He applied enough plaster to have a wadding that was 1 inch thick, and then enough padding, sorry, to have a wadding that was 1 inch thick, and then compressed it with a tight plaster cast that came down to 1/8 of an inch. So I think that's it's slightly different to what we do today. And this was lifted and rolled more around the limb. So Charnley tells us that the hallmark of a good plaster is that it should have an even thickness from end to end. I think that holds true today. And it also reminds us that it's not just the first and the last layers that are important, but need to be mindful throughout applying the whole plaster. So I think the more probably modern techniques and adaptation of some of the principles in both those. So obviously achieving fracture reduction, but then in the wool-based fabric, applying a 50% overlap, so it's only 2-ply thick, which is different to Charnley's that had a 1/2 inch thick interface. Obviously padding some of the more bony prominences in order to avoid pressure sores. And then when we're applying the plaster, I think it's important to remember to pay attention to the tension, to have an even thickness throughout. Needs a 3-point mould in order to maintain reduction. I'll come back to that. And obviously being aware of pressure areas. So this is an example of a few things. So it's Charnley's badly padded plaster. So you can see that the interface between the plaster and the skin is thick. There's no real moulding to hold the skeleton where it needs to be, and it's an uneven cast. There's lots wrong with this one. I'll put this up just to show, unfortunately, some of the things that we get from ED departments and elsewhere that have not really held on to the principles that we've been talking about. So to go back, Charnley, he described a triple sequence that he wrote quite a bit on how he thinks the plaster should be applied, and I think there's some good points in here, that's why I put it up. So he says the first thing you should do is examine the limb, reduce the fracture, but then also find where the fracture is stable and spend time planning and rehearsing the mould that we're going to give. And then when plastering, he tells us that we should use a very wet plaster and get it onto the skin as quick as we can in order to give more time for moulding. And then that third phase is applying that movement that we've already rehearsed and practiced in order to maintain the reduction, and then holding that reduction until the cast is set, which I think is important, and then coming back for the finishing touches. So to come back to the 3-point mould, there's that old adage that bent plaster, straight arm, and this makes use of the soft tissue hinge to maintain the reduction of the skeleton. I think it's important here to remember that plaster is not merely a passive mould. It has to exert pressures on certain parts of the skeleton. And so this is just demonstrating that 3-point mould concept. So the idea in that first picture is that fracture reduction is maintained by applying appropriate forces. However, if you use only a 2-point mould, and these are usually achieved by the surgeon's hands at the time of setting the plaster, unopposed forces will cause the plaster to rotate around the fracture site and then ultimately become a displacing force. And that's why that third counterbalance is needed in order to maintain that reduction. There's been a few studies looking at trying to develop objective measures for measuring what makes a good plaster. So the cast index is one that's widely quoted, and this is taking the ratio of the sagittal to the coronal width from inside the cast, taken at the level of the fracture site, and a ratio of less than 0.8 is associated with a lower remanipulation rate. I'll come back to that in a little bit. So this is just a stylized picture of that again. This is a article published in JPO last year that were trying to find what cast index was associated with a high remanipulation rate. And so they retrospectively reviewed over 1,000 children. These are children that had a GAMT for displaced forearm fractures. And they considered redisplacement at their 2-week x-ray as greater than 50 degrees angulation or greater than 80% translation. In their series, they had 107 cases with displaced, which is 10%. And they found that those with the cast index of less than 0.8 had a much lower displacement rate of 5.58% compared to those with a greater than 0.81 of 26%. So this was statistically significant at a threshold of 0.8. And they also found that they had an inter-observer reliability that was favourable. Just as an aside, they also found in that study that independent risk factors for displacement were obesity, excessive padding, and significant soft tissue swelling. And these all go towards that distance between the plaster and the mould to the skeleton, and that loss of position there. So there's several other ways that have tried to, several other indices that have tried to look at what makes a good cast. I think it's like most things, if there's more than one way to do it, there's probably a reason for it. So I'll just go through some of these briefly, but the gap index measures the space between the cast and the skin as a ratio to the inside diameter of the plaster. This is not a validated measure. It's only been reported in a few small case series. The next is the padding index. So this is the dorsal gap on the lateral film divided by the maximum interosseous space in the AP. So I'll show some pictures of these in a moment to make more sense of them. Again, it's a small case series and it's not validated. The Canterbury index is a combination of the cast index and the padding index. This has some evidence to say that it has specificity for predicting what cast will need remanipulation. But again, there's not a whole lot of evidence and it's quite cumbersome. The second metacarpal radius index is measuring the long axis of the radius and the second metacarpal, and they have that as a greater than 0 is associated with a higher loss of position. And then finally the 3-point index. There's quite a bit to calculate there, I'll come back to that. So this is again a picture of that cast index showing how it's calculated with the cutoff value of 0.8. This is the next one, the padding index. So this is the one measuring the dorsal gap between skin and plaster and comparing that to the interosseous space with a cutoff value of 0.3. So again, that hasn't been validated independently, and I don't think it has much use clinically. This is an example of the second metacarpal radius angle. So this one's showing I haven't measured, sorry, but that angle is greater than 0. So this would be a cast that they, using this method, would suggest that it has a higher remanipulation rate. This is the gap index, and you can see we're getting more and more complicated and cumbersome. And then finally the 3-point index. So adding up all those values to come out with a value to try and predict which ones are associated with a higher loss of position. So again, this one's largely limited by, this one theoretically is thought to have in theory is meant to have the best principles. However, you can see it's I think the clinical applications, it's too cumbersome for any routine use. So going back to compare all those methods, this is again another article in JPO last year that tried to compare all those and provide an independent review of do they actually have clinical significance. So they retrospectively reviewed 155 patients. They found 3 main things. So their independent risk for loss of displacement was initial displacement of greater than 50%, failure to achieve anatomical reduction, and then again that cast index was shown to be useful. So this is just comparing those indices. And there's a lot of data there, sorry, but if you have a look in the very first one, that cast index is the only one with the statistically significant p-value. Let's quickly go through some other techniques with plastering. So the idea of wedging a cast. So this was taken from a JOS article from a few years ago, where they described their technique of wedging, which I thought was quite good, because in the past what I've seen is sort of just a best guess method. So they use the lateral radiograph and make a template of the position of the fracture, and then use that to transfer it onto the plaster. So when they cut around, leaving that volar hinge that you can see on that bottom picture, by straightening that cast so that that line becomes straight, the idea is that the bone should also be straight under the plaster. So this is a more local picture. This is a patient we've seen in clinic recently. I think this guy's a 7-year-old that had a mid-shaft tibial fracture that was managed with a GAMP. That picture on the left was the 1 week x-ray where it had tipped into a little bit of varus. So we wedged this one in clinic, and I think we improved the long axis there to some degree. So obviously this is one that's again at risk of slipping, and keep a close eye on it. But I think it demonstrates the principle of what we're trying to do. So just very quickly, there's debate in quite a few studies on comparing plaster cast to fiberglass. I've tried to sort of summarise a lot of that in this table. So the cost per roll varies on the size of the roll, but roughly it's about $5 for the 6-inch that we use here, and about $10 for the fiberglass. So per roll, plaster is cheaper. However, there's been quite a few studies that have looked at the costs associated with recasting and durability, the time taken to reapply those casts as they wear out, and fiberglass comes out as the cheaper method. The flip side to that is that plaster has a greater ability to mould, and I think most people would agree with that, that fiberglass is a bit stiff. So I think the role of plaster in that early maintenance of a reduction can't be debated. Fiberglass has a lower setting temperature than plaster. The other use that we use it commonly for is it's more radiolucent than plaster. So when trying to look at fracture lines and things, it's much more user-friendly in a clinic setting. As you said, the fiberglass casts have a greater durability. There's been several patient studies that have looked at what they prefer and how usable or how easy it is to perform activities of daily living with these plasters on. And again, fiberglass comes out as the preferred, patient-preferred material. And then looking at risk for pressure areas and irritation, fiberglass is associated with higher areas of rubbing, and that's because of the sharp edges on it. Thank you. Who speaks French?